I've got 2 kids and a diabetic dog that pees 7 times a night. It's true. I wish I was kidding. So I don't sleep a lot, and when I travel, I get all excited because I'm going to go to a hotel and I think I'm going to sleep. And then I get to the hotel and I turn on HBO and it's Game of Thrones in Spanish, and I'm like, yes. So I'm not kidding. I sat up in my room last night and watched Game of Thrones in Spanish, like 2 episodes. It was awesome. My wife and I vacationed in Cancun a lot, and her whole thing was by 2018, we're going to speak Spanish. I'm like, I don't think it happens that fast, you know, Rosetta Stone, whatever. So I do. I watch a lot of HBO in Spanish. So that's my story. Thank you, guys. We'll see you next time. There we go. No, I like people to know why I drink so much caffeine, and that is why. And the other reason is, who here knows Adam Russo? Somebody? He's my boss, and I try to keep up with him in terms of how I speak and how I present. I just can't do it. I'm from a small town in Idaho. I'm pretty laid back, so I drink enough caffeine and I get going, and it works out just fine. Super quick before we get going, let me tell you a very quick background about who I am, the FIA Group. I think a lot of you are familiar with the FIA Group, but I don't tell you all this to sell you something, but it helps hopefully to provide some context into who we are, what we do, and how we know what we know or what we think we know. And then that way it helps with what I'm talking about today. I've got a clicker here. Let's see. Look at that. So the FIA Group is a cost containment firm, essentially. That's how I explain it on airplanes. When people say, what do? I just say I work for a cost containment firm, and I hope they don't ask any more questions, and I can go back to something else. Out of Boston, Massachusetts, privately held, small firm, about 18 years old. Started out doing primarily subrogation, okay? That was really our bailiwick for a long time, subrogation and recovering third-party dollars for self-funded health plans. Over time, that allowed us to turn the lights on, bring other services to bear, and our primary other service packages today are anything from plan docs to claim negotiations to fiduciary transfer service, and just general consulting. We're not a law firm. We have about 15 attorneys on staff. I know a room full of doctors, you're supposed to go, boo! It's like the softball game, doctors versus lawyers or whatever. But we're not, and this is important, we're not anti-doctor. Our relationship today is going to be built on 45 minutes, and a lot can be misunderstood in 45 minutes. So when I say cost containment firm, when I say healthcare attorneys, when I say claim negotiation, a lot of times people in the medical community go, oh, you guys are those guys. We're not those guys. We're good friends with Dr. Keith Smith, okay? Marty Macri. A lot of people in the medical community, we are passionate about what you're doing here. Passionate. We know that it's not the providers that are necessarily driving costs up. It's large systems, it's things that are out of control that most of you don't have any visibility into. Okay? And I know there's a lot of different people in the room from different backgrounds, not all doctors, but I say that because, you know, in a room where we do have medical professionals, I want you to know that we're on the same side. I will say some things today that you might be like, but just don't throw stuff at me. I got a plane to catch. I got to go to the rodeo outside of Boise tonight. My daughter's mutton busting. True story. Okay. We have a lot in common, Oklahoma and Idaho, right? Is it too soon, Oklahoma folks, to mention that my wife went to Boise State? Yes. That was a good game. We have it on DVD. That's how pathetic we are. We're like, that was the best game ever. We watch it all the time. See, we're all friends. We're good. This is what we're going to do today. First off, I told you the FIA Group. My background, so I'm a small town boy from Idaho, grew up on a cattle ranch. Literally one day I'm a teenager, my dad sells out. I go, oh. So I followed my buddies to school. I got a degree in history, which was useless. Followed my roommate to law school. Truly, because he was a really good roommate. He was from Wyoming, second best fly fisherman next to me. And so we went to law school together. That is why. I didn't have any delusions of grandeur. I didn't know I was going to be doing this. And through the years, I just sort of fumbled through it. Years ago, ended up working for a TPA, third-party administrator, in the self-funded space, general counsel, then came to the FIA Group. That's how we all got here. With that, today, let's talk about critical strategies in self-funding to promote the free market, okay? First off, I'm going to go over some problems, things you all know, but we'll just spend maybe 5 minutes talking about pricing, talking about what's going on, what's causing those issues. Then, what I want to do is shift into how, in my opinion, the employer-sponsored, self-funded health plan, as administered by a TPA, again, in my opinion, might be the prime model to help fix a lot of our problems. Some folks will disagree with me, that's fine. That's where I'm going to go after that, is talk about self-funding and that employer-sponsored self-funded health plan through a TPA and what it can do to help solve the problem. From there, what I want to do is actually give you some tangible takeaways, whether it's from the provider side, from the TPA side, from the employer-sponsored self-funded plan side, some actual tangible takeaways, things you can think about that you could employ in your space to start driving costs down, to start creating this free market. Okay, there's a lot of ways to create a free market. One of them is you can kind of force it. And so that's some of the things I'm going to talk to you guys about today. Now, in the short time we have, obviously I'm not going to give you all of the ingredients to make a stew, so to speak, just some high-level stuff, hopefully give you some ideas and kind of noodle on them, ask some questions. Garrick, the bald guy sitting up front, he's going to be here all weekend, or I guess through Saturday night. I do have to boogie right after this, and I do apologize for that, but please, if you have questions, again, not to hire us, just to talk about this stuff because we love it, find Garrick, okay? So this is Garrick up here. Garrick, big wave. He's from Boston. He's got a much cooler accent than I do. Okay. Why are healthcare costs out of control? I'm not telling you anything you don't know. The previous presenters did a wonderful job. Appreciated so much what they had to say. There was conversation about transparency. We know that. So much lack of transparency. You go to Home Depot to buy a refrigerator. How's that go? It's a little different. You actually look at the price tag. You go over to Lowe's, you look at that price tag, and you go, well, this LG fridge is $200 over there, cheaper. Go back to Home Depot, they'll probably knock the $200 off. You buy a fridge, you know what you paid for it. If you go to Home Depot and they said, well, we don't put the prices out here. Just buy it, take it home, fill it with food. A month, or 2, or 3, or 4, or 5, or 6, or 7 months from now, you'll get a bill. What's it going to look like? Yeah, it'll be on paper. I can tell you that much. What other consumer experience is like our world? Our world's insane. And I'm not blaming anyone. I'm blaming all of us. I am, okay? It's convoluted. It's confusing. There's a lack of transparency. We have the wrong incentives, readmissions, things of that sort. This is some of my favorite stuff. So I mentioned earlier, the FIA group, we do a lot of claim negotiation. Typically out-of-network stuff. You know, we're not in this to try and hurt the providers and put you guys out of business. We're in this to make sure that things are fair. So this is from experience. These are some of the things that we worked on. My favorite is the $985 pair of scissors, because my 7-year-old daughter should be able to run around, fall down, and stab herself in the face with those scissors, and they won't hurt her for $985. Wouldn't you agree? Those have got to be the coolest, safest, best scissors ever. $11 for a mucus recovery system, a box of tissues. I'm in the wrong business. That is an incredible markup, right? So these are some of the things that when we start paying attention, we see and we go, what's going on here? It's out of control. Some of the worst offenders. Again, don't throw anything at me if somebody in here is like, I am an air ambulance provider. I love it. I'm from Idaho. Ambulance is very important. We're in the Rocky Mountains. Trust me. I actually do have a lifetime membership to St. Luke's Air Ambulance for skiing. But markups are crazy. Implants, notice where I say providers are getting gouged on the procurement side as well on implants. Downstream, upstream, the whole food chain of the pricing mechanism is out of whack, right? I'm going to kind of blast through this stuff because you guys know this. You guys know what the problems are. I want to get to the solutions. Did I break it? There it is. Wrong incentives, protectionism, overtreating. I think I broke it. Ha! Okay. Here's where I shame everybody. This is like Las Vegas. This is a safe place, right? Actually, Las Vegas is not a safe place, but this is a safe place, this room. And what I mean is let's all be on the same team here. I think for a long time, healthcare attorneys, cost containment firms, claim negotiators really wanted it to be us versus them. And by us versus them, I mean the good guy healthcare attorneys fighting the mean doctors. That's not the case. If we're being honest, it's all of us, even down to the plan sponsors, even down to the plans administered at Ed and Robin's shop. And what I mean is, anybody who's tolerated paying an amount they shouldn't have, it did start with the billing, so there's blame there, but then we paid it. Whether it was on a fully insured carrier model, whether it was a self-insured model at a TPA, we all bear responsibility. So I make this joke, If you feed a dog steak when you bring him home, he's going to expect steak for every meal, right? And to be clear, my wife saw this slide and she's like, are you comparing doctors to dogs? I'm like, no, it's just, no. I could see, no, honey. I was like, no, I thought it was funny. It's a picture of a dog and a steak. What I'm trying to say is manage expectations. Manage expectations. Sometimes we've got to eat a little tofu, okay? So, point is, we're all in this together to try and fix the problems. A free market. Let's create a free market together. How can we start to do that? I'm a firm believer, and the cool thing about today's conversation, a lot of times when myself or the other folks from the FIA group are presenting, we're presenting to a room full of third-party administrators or full of brokers that do nothing but function in the self-funded space. And I know we have people like that in the room today. But I'm excited that we have other folks in the room, the provider community, other people that are like, gosh, I'm not that familiar with this self-funding thing. Why are you so passionate about it? So it's a quick opportunity to tell people like Jim stuff he already knows so he can zone out for 10 minutes and answer emails. But for everybody else, maybe it's an opportunity to tell you kind of how we see the world in terms of a payment model that makes sense and how it can help to push us toward that free market, okay? This is a big honesty test. No one will shame you, and I will thank you for it. Someone please raise your hand if you're like, I have no idea what this self-funding business is. Tim, you're babbling at me. Yes, 1, 2, 3. There's more. See, it's safe. It's safe. It's like Spartacus. I'm Spartacus, and then the next one stands, and then there's 100 Spartacus. It's very exciting. So, right? It's a good movie. So, at its core, self-funding is where an employer sponsors its health plan, pays its claims out of pocket. I'm making it much simpler than it is, but that's a really quick 60-second way to understand it. Employer sponsors a health plan, but doesn't go over to Blue Cross, United, Cigna, Aetna, doesn't pay a premium to have a fully insured plan where this entity bears the risk and pays claims. Rather, the employer sponsors the health plan, pays those claims out of its pocket. Again, there's much more to it than that, but ultimately that's what you need to know, okay? Now, I should say Meg or somebody can confirm. I'm sure these slides are available. Perfect. So, there's some terms on here. You're like, I'd like to know more. I'm interested. Just however you get the slides, PDFs. If you have some questions, ask us, ask me, ask some of the other folks that are passionate about self-funding. That's really what you need to know, okay? There's really two ways an employer can self-fund. There's more than this. Again, I'm making it simple. One is through a TPA, one is through an ASO. I am passionate about the TPA space. I call it pure self-funding. Pure self-funding. I'm sure other people have said that. I didn't coin the term. I hope I didn't. But I truly believe that the best model for an employer-sponsored self-funded health plan to have ultimate control over the data, ultimate control over your benefit structure, and how you're paying claims is through a third-party administrator. I'm very passionate about it. These are the two models. ASO is carrier-owned, administrative services. ASO, administrative services only. I'm not bad-mouthing it. I just prefer the TPA model. ASO is a good model too. ASO is where Blue Cross or someone else might say, hey, we're stoked about this self-funding thing. We want to dabble in this space. You, sir, have a self-funded health plan. You are an employer. You've got 1,000 employees. Your broker's helping you place it somewhere. Says, here's some options. We can go over here and have it on a carrier. We can go over here, these TPAs. You go, tell me about the carrier. That would be the ASO. Names you're familiar with. Maybe you feel safe there. But to be candid, the flexibility isn't the same. You own your data, but not really. So if you want to get your data to do some predictive modeling on claims and health spend, it's kind of hard to get sometimes. The TPA model is a little more flexible. It's unbundled. It's a la carte. There's a lot of cool stuff you can do there. We could do hours and hours and hours on this for people who are maybe not familiar with that model, but I'll just leave it there. That's what you need to know for the rest of this conversation. Employer-sponsored, self-funded health plans, bearing their own risk, paying their own claims, and in my opinion, the TPA model is the way to go. Boom. Yeah, drop the mic. Why do I think this is one of the keys to the solution And why do I think this is so important to creating a free market? In this space, the self-funded space, on a TPA model, you can kind of do whatever you want. I don't mean like rob a bank or, pour gasoline on your neighbor's lawn, like weird stuff. I mean like how you administer your plan, the benefits you pay, the cost containment measures you have in place. There's so many things you can do. So many things you can do. It's usually network people that go boo when I put this slide up. In a pure self-funded space at a TPA, you could say, I don't want a network. I want to do something aggressive. I want to get out of the network. I want to do some reference-based pricing, which we'll talk about in a few minutes. Or most TPAs lease some networks, which is also great. And what I mean by that is we're self-funded. We're an employer-sponsored self-funded health plan. My people, my belly buttons that work for me that are on the factory floor making widgets, they like the Nike swoosh, the Blue Cross, whatever symbol they're used to on their card. We can make that happen in the TPA space. Great. Let's go out and we'll lease the network, then go to those providers. It'll be exciting. But what I'm getting at is if that's not for the employer, if they'd like to do something different, push the envelope, be a little more innovative, they can walk away from these options. Okay. I'll take a drink of my coffee here. Ultimately, one of the reasons that a self-funded health plan can do so much cool stuff is the plan document. That's what so many other people in the insurance industry might refer to as a policy. It's this governing document. It's very short. It's about 120 pages. And your average employee can absolutely understand every piece of it. Very easy to read. The plan document, truly though, and all joking aside, the plan document, get some consultants, get a good TPA, good broker, work through it, and really structure it. What do you want to pay and why? What do you want to cover? What don't you want to cover? Whereas, in a fully insured model, you just go buy your policy. You got 2 or 3 options, and that's it. Which again, that might be great for some people, but if we want to get into a world where we're controlling cost, we're paying claims at a reasonable rate, this is the way to do it. And again, I'm throwing up a lot of terms and stuff up here that are like, nah, and I know it's, in 45 minutes to an hour, we're not supposed to go over all these terms. I just want them in front of you. I just want you to see 1 or 2 things that you're interested in. You take 1 or 2 nuggets, and then maybe there's some follow-up. Are you guys clicking for me, or am I just thinking it? You are? Okay, I didn't know. It's like I just... I wasn't... Okay, real mechanisms to promote the free market. Now what I'd like to do, let me backtrack for a minute. Just talked a little bit about high level, what are some of the problems? We already knew all those. Number 2, I provided a high level overview on self-funding, and especially in the TPA space, which I'm passionate about, and I believe is a really, really good model to help promote the free market. Now, let's start talking about some real mechanisms to get us there. But first, and this is like the last time I get to do this, I've shown this picture in like Dallas and in DC, Boston, Anaheim, Vegas, and I think I'm coming up on a year. Jim, I don't know, I'm trying to think, there's people in here that have seen this before, so you guys know that the runway's run out. I probably give this picture another month or 2, and then it's like, okay, Tim, you've shown it in every presentation. Rick, have you seen it? You like this one, okay. So, this actually is important to our conversation today, but it's also a moment to just have a little fun. Because although everyone here is passionate and we're talking about some good stuff, day goes on, you get a little tired, you have a little lunch, it can be kind of boring at times, so let's have fun with a quick story. And it all has to do with healthcare delivery. 2 quick stories. So whenever it was, a year and a half ago, I'm speaking at a conference in Vegas. And anybody that goes to Vegas knows the routine. You can pay $109 for a beer, or you can go to like Walgreens and buy a half rack and put it in your room like a reasonable human being. We're all free market people. This is like the best crowd to understand that story. So that's what I do. I go to Vegas all the time. There's that Walgreens that's kind of over by Planet Hollywood, right? And this event was at the RAS. So I take the little skywalk thing, I go to the Planet Hollywood, I get my Rolling Rock, looked good at the time, and I'm coming back, and like a good boy from Idaho, probably you guys here, Texas and Oklahoma, you have You also have camouflage sandals like I do. And not because I'm an idiot small-town guy from Idaho who's never seen an escalator, and not because I was drunk, because I wasn't, just wasn't paying attention. Escalator. And you know, as the escalator starts to open up and there's all those teeth across the top of each step, I trip and I jam my toe into it. Yes, it was awesome. And it just, and it goes in it and tears out the end. So it wasn't like it cut it or poked it. It poked it and tore out the end. And again, you guys will appreciate this. I feel we have like a lot in common. I tell this story in like New York City and they're just like, but I think, and I know I'm in a certain type, but I'm a country boy. I drive an F-150 Super Crew extended cab. You guys know what that is. Like a good boy from Idaho, I'm not like, ow, I'm hurt. I'm like, oh man, I hope nobody asks to help me. And there's blood going everywhere and I'm like squishing along and I'm standing there and I'm like, shit, you know. And then the tram is there, the tram is coming, and you get in the little tram to go back to the Aria, and it's like, and I'm like, I gotta get back. So I figure my best option is to find a sanitary public restroom on the Strip, which is what I do, and I lock it. I found the family one that you can lock, right? So it's like lock, and like in the movies, I'm like, I'll put some alcohol on it. So I pour Rolling, which is like 4%, like. You can go back. You don't have to, okay. I did that during like a breakfast presentation at like 8:30 in the morning once, and I pretended that my clicker was broken and just left it on that, and people were like, "Ah." Long story short, I'm presenting, you know, I get all cleaned up and, you know, life goes on. The next day I'm presenting and I'm sort of like, you know, doing this and hurting, and I fast-tracked these pictures into my presentation, and I was presenting to a room of first responders, EMTs, firemen, paramedics, etc. And one of the guys in the back just like, and you know, they're all like, the mustaches, and he's like, what is your last tetanus shot? And I'm like, I don't know. And he's like, that's important. And I'm like, you know what, lockjaw, no big deal. He goes, no, your lungs will quit. I'm like, and I know there's medical providers in here, you guys probably knew, I didn't know that, and I don't know if I'm being dramatic by saying quit, that's how he put it. And I'm like, I should go now, right now. And he's like, you can finish your presentation. I'm like, really? So all that long lead up to now talk about medical delivery. So I Uber to an urgent care clinic off the Strip. I'm from Idaho, very familiar with and own a lot of firearms. However, I've never been in an environment with so many firearms that made me so uncomfortable. Armed guards, they had like bars on the windows of the clinic, and I'm like, what is this? And they're like, you know, so it works out. I go up to the front desk, and Garrick, you can be the nice lady at the front desk, and I say, hi, you know, blah, 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 and, you know, I'm smart enough to know, like, I probably need stitches, I might need a tetanus shot, I don't know, can I get in? They're like, sure, we need your insurance card. And I go, great, I don't have it. My wife texted me all the information, and I wrote it down on this sticky right here, and I hand it to her. She goes, well, no, sir, I need the information off of your insurance card. And I go, this is the information off of my insurance card. And she goes, no, but I need the information off of your insurance card. And I'm like, so I go, well, this literally couldn't be any more off of the insurance card. Like, it's right? Like, I mean, it literally, and I'm like, it is. That is off of the insurance card. So we do this weird thing, and we're just doing this. And she goes, well, okay, sir, who are you with? And I'm like, well, my wife works for Albertsons. It's Blue Cross of Idaho. Now, mind you, those of you that are familiar with Las Vegas know that if you drove north long enough, you'd run into Idaho. We border Nevada. She goes, Idaho, where's Idaho? I'm like, and she goes, is it affiliated with Blue Cross of Nevada? I'm like, well, you guys are all blues, you know, can we just do this? So then it kind of like falls apart, and I'm like, I'm very polite, and I don't want to do the food chain thing of like, can I talk to someone else? But I'm like, is there someone? And so then I just say, hey, I'll pay cash. I was like, to hell with this. And this is going to sound crass. This is going to sound like, oh, I make enough money, I can do this. But in all sincerity, I figure with what I do for a living, I should do things like this from time to time so I can speak to them. My wife, she's an amazing, amazing career woman. We do well enough that from time to time, if I want to do a stupid experiment, I can. So I go, I'll pay cash right now today. And she's just like, you can't do that. And I go, And I'm like, this is America, right? And she goes, yes. And I go, so, I was like, that's just so counterintuitive to me. I was like, I want to pay you money. I want to pay you guys money right now. I'll give it to you. There's no billing. You won't have to chase me down. I will pay you for services rendered. Like if I hired Garrick to paint my house, he would paint my house, I would pay him. It would be exciting, it would be wonderful. And sir, you can't do that. And she actually says to me, that's illegal. And I go, ha! Do you know what I do for a living, man? Right? I'm like, it's illegal? How? Free enterprise, how is this illegal? And it was great because she goes, well, you have to use insurance. I go, I do? Why? I go, right? So that was the first time I reported as self-pay. It didn't go very well. And I also learned that day that there is a window of time within which you have to get stitches or you can't. I didn't know that. I get in there and the doc says, you need stitches, but I can't give them to you. Good luck. Let's clean it out. You know, Q-tip and the whole 9 yards. So I learned a couple things that day. The other one, and then I'll move on so I don't bore you to tears, was I went to a little clinic once with a sinus infection. I'm smart enough to know I had a sinus infection. I needed a Z-Pak. So I walk in and I do the same thing. I'm very polite. And I was sincere. I was going to pay them cash money that day. And I just go, hi, I'm not pretending to know what's going on, but I'm pretty sure I have a sinus infection. Just need to get in and out, probably some antibiotics or whatever. Can we do this and just give me a ballpark what it's going to cost? And, you know, God bless her. It's not her fault. It's not her fault, right? That's another thing here. Not her fault. The person working that front desk, why would they know? They've been trained, take an insurance card, put it in the system, high five, smack them on the butt, get them out the door. Okay, right. So I was like, no, I will pay you cash. Same rigmarole. I did finally get in. This part was awesome. This part was awesome. And I believe this from the bottom of my heart. And what I said earlier, we're friends. I know that the individual provider, the individual clinician, you in the room that fit that role, you guys aren't the problem. It's a big system that you're a part of, that you don't have any visibility or control over either. Every once in a while, just like lawyers, just like cops, just like anything else, there's a bad one though. This doc, this is crazy. You guys would be ashamed of this dude. We get in there and he's like, yeah, Z-Pak, whatever, blah, 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 blah. And he goes, and I'd like to give you a cortisone shot, which I was like, okay, a little steroid, let's go. And I go, well, what's that going to cost? He goes, don't worry about it. Insurance will cover it. I go, no, I'm going to pay for it. And he goes, oh, you don't really need it then. I was like, oh. It was a special moment for both of us. Anyway, look at that. I just thought it and it clicked. This is so weird. You guys are doing a good job back there. All right, so what I'd like to do, thank you for letting me tell my silly stories. What I'd like to do now, recapping again, we talked about some of the problems. We talked about third-party administrators, self-funded health plans, and how that's a model that we can do a lot of cool stuff to help promote a free market. There's a couple ways you can get to a free market. You can get a bunch of people together and it can sort of just happen, or if the powers that be and the forces are aligned against us, we kind of have to force it. We have to disrupt a little bit. Sometimes there's pain. Okay? But the end result, the end game is good. What I'm now going to do is talk to you about some mechanisms that are in the world that I'm very familiar with, again, which is self-funding. Okay? Some mechanisms that we employ to push toward that free market model. And again, I'm going to acknowledge some of them are disruptive. Some of them can cause a little pain. That's not the point. I think we all know that change comes with a little bit of pain. The point is the end game. The point is a better and fair system. And I'll also acknowledge some of the things I'm going to talk about aren't for everyone. Let's talk about them. Reference-based pricing, RBP. I know there's folks in the room, especially people I'm familiar with in the TPA space that I meet with and talk to all the time. This is old hat. This is stuff you know a lot about. But I'm hoping there's some folks in the room that you're like, I think I've heard of this. I think I don't like it because I think it doesn't pay what it's supposed to, and maybe that's a misnomer and I can help that a little bit today. Safe spot again. Please. Is there someone in the room that when I say reference-based pricing, you're like, I have no idea what you're talking about? Awesome. Spartacus, we get more hands going up. Very good. Reference-based pricing, again, because we have limited time, I'm going to make it very simple. It's using a benchmark. It's using a reference point to establish a fair reimbursement rate. I want to emphasize fair, because again, I think there can be a misunderstanding when it comes to cost containment, healthcare attorneys, claim negotiators, and the provider community. regarding the end game. There's some firms out there, some individuals that they want to scorch the earth and they want to put providers out of business and they don't believe in fair reimbursement. That's not what I do. That's not what we do. And I would argue I don't think that's what a lot of my peers do. We're really pushing for a fair model for everybody, okay? So I'm going to use the Medicare example. There's other ways to effectuate a reference-based pricing model, but the Medicare model is one that's easy to understand. It's quick. It's one that we work on quite a bit. This is where you might take Medicare as your reference point, and then you will pay based off of that. You get a claim. A claim comes in, knee surgery, whatever it might be. And then you can analyze the Medicare data to understand what is Medicare paying for that procedure in this region. We understand like minds can differ. Medicare is either a wash, or you're either losing money, or you're either making $1. Either way, not a lot. So that's why, to do this appropriately and to be fair, you use Medicare as your starting reference, and you say, we'll pay 150% of that, 200% of that, whatever. For example, there's a lot of leeway there, okay? A lot of leeway there. But again, we use a benchmark, a starting point to understand a fairly accepted price point, albeit low, but then we add a margin to make it fair. Okay? Does that make sense fundamentally? Some people love it, some people hate it. I'll acknowledge that. I believe, and I think you can see, as you walk through a reference-based pricing model in your head, you can see how the end game starts to create maybe a free market, something like a free market, maybe not everywhere. Okay? Reference-based pricing. There's other ways to do it. This is just an easy one to understand. Any questions about that? I mean, we could go off way into the weeds for hours and hours and hours, but instead let me pause for a second and see if and I don't know the rules. I don't know if I'm supposed to wait till the end for questions, but FIA doesn't follow rules. We don't. I kicked over a chair in Anchorage once. I was speaking at the Alaska Association of Health Underwriters. And I was like, I said something, and I was like, I kicked a chair over, and everyone's like, whoa. And it was like so many other organizations, you'd do that, and they'd be like, call the president, be like, your vice president of sales kicked over a chair, you know, and I was like, God, I hope they do call Adam Russo. He'd be like, yeah? Click. Anyway, sorry. So reference-based pricing. Again, what I'm trying to talk about now is mechanisms that you can put in place, mechanisms in the world that I'm very familiar with that are assisting in pushing toward a free market. It causes disruption. It causes some pain. Let me click through. Let's do it. Oh, look at that. Why reference-based pricing? Why? Because the starting point on so many of these prices are out of control. We already talked about that up front. I just wanted to provide some other examples. Because when I say Medicare plus 50%, Medicare plus 100%, Medicare plus 200%, people sometimes think, wow, that's still really low. But look where we're starting. Look where we're starting a lot of times. Dialysis? Is that my next slide? Go. No. Bad guess. Dialysis. Here's a really good example. Is Fresenius or DaVita here? Why would they be? Are they, though? Like, seriously? That would be wild. Thank you. I don't dislike you guys. I will probably need dialysis someday. So I'm not picking on either. It's just those are the two. I have seen, and I've worked on a lot of cases where it was very interesting, is a lot of times dialysis claims are coming in initially priced at anywhere from 1,000 to 2,000% of Medicare. Okay? 1,000 to 2,000% of Medicare. Now, in defense, I need to be fair. DaVita, Fresenius, and I don't know that I would disagree, would say, well, you know, Tim, we get just destroyed by Medicare. So that's why on the private pay, we need to mark it up 1,000, 2,000% of Medicare. I've heard that argument all day. I don't buy it. If there's 1,000 diners on the New Jersey Turnpike, and the last one charged $1,000 for a ham sandwich because most other people stop at all the other diners, maybe that last diner needs to go out of business. Free market. Boom. Okay. I just Davita, don't chase me down in the parking lot. I got to get home to my daughter. She's beautiful. She's a wonderful person. All right, let's go. Where are we going? Let's see what we got next. Styles of RBP. Love this example. So you're going, well, interesting, Tim. You've talked about something that is a little bit disruptive. What do you do? How do you do it? You can go naked. A self-funded health plan could go naked. Not for everyone. Definitely not for everyone. Risk. What does go naked mean? Go naked means kick all the networks to the curb. Establish a reference-based pricing model on your health plan for all claims. We will pay every single claim that comes in the door at 200% of Medicare. Even if there's no Medicare data. I don't know what we'll do then. We'll figure it out. You can see that's risky. You can see that's probably going to create some balanced billing, right? Fair enough. Create some noise. Johnny Six-Pack, the belly buttons, the people that actually work for the employer, they're probably going to go, I don't know what's going on, and they're going to have a misunderstanding. Is my insurance paying? Is it not? Do I have insurance? What's happening? I'm getting a balanced bill. I'm so confused. So a lot of employers get scared of this model if it's not rolled out correctly. Wearing pants only. So sort of like half reference-based pricing. Maybe you have some direct contracts. I've heard mention of that already today. Maybe you have a network, but you say, we're going to do reference-based pricing. We're going to pay 200% of Medicare for out-of-network claims. That's a model that seems very safe, seems very reasonable, seems very fair. And it's a good intro to the reference-based pricing world. Okay? So again, what I'm trying to do here is just kind of talk to you about some of the styles of reference-based pricing that are out there. Maybe in a minute or two, familiarize yourself with those. Okay. Let's see how we're doing on time here. Hey, we're doing good. My wife says, if you want to go to your fantasy football draft, you totally can. We don't have to go to the rodeo. I think I go to the rodeo with my wife, is the correct choice here. Facets of a successful program. Here's something where hopefully I can really bring everyone in the room together. Some people, especially in my role or my firm's role, that want to promote a reference-based pricing platform, again, it's us and them. It's not we're in this together. It's let's cram this down their throats. We're going to pay 200% of Medicare, and if they push back, we're going to lawyer up. It's going to be scorched earth. That's not sustainable. And your friends and neighbors, lawyers, doctors, we all want to golf together, right? But truly, so a successful reference-based pricing program, a successful pricing program on a self-funded plan that might be a little bit disruptive has a couple components that might make it a little more successful, less disruptive, and that it could push into the community and get us closer to that free market. Member education. This is cool because this crosses physicians, clinicians, attorneys, TPAs, employers that actually sponsor the self-funded health plans. So many people leave out those members. My fictional Johnny Six-Pack, the belly button, the guy that works on the factory floor making widgets. The employer rolls out a reference-based pricing plan. They hire a firm like ours to help them do it. But somewhere in there, they don't have a lunch and learn. They don't have multiple open enrollment meetings to say, hello, my 1,000 employees. Let me tell you about reference-based pricing and what it's going to look like, what it's going to do. And we're going to engage our local provider community. We're going to have patient advocates that are not there. I know the word advocacy could be a misnomer because it sounds like it's confrontational. But rather, we're going to have patient advocates that are going to go out and work with our provider community. Make sure everybody knows we're a large employer in this area. We want our people to go to your health system. We want to pay a fair rate. And the end game, maybe we can get some direct contracts. If I promise you prompt pay, you're going to get paid within 14 days, 21 days of submitting a claim every time. Would you agree to take 400% of Medicare, for example? Varies by region. But those are some of the keys to a successful program. Education, transparency, discussion up front, bringing all the stakeholders to the table. Okay? All right, let's click through. What do we got next? I like this. Is reference-based pricing illegal? Yes, no, we don't care. We don't like it, we love it. TPAs, I sure hope it's legal because we're doing it. Bottom line, RBP is legal. Absolutely legal. Just because something's legal doesn't mean it's a good idea or a bad idea. You need to go into it carefully. And again, I hope my last slide, my last little bit of discussion resonates maybe more than even anything else I've said today about all the stakeholders. If you have a disruptive pricing model, something that's pushing us more toward this free market, let's do it together, okay? And don't forget those members. All right, what do we got next? Let's go. Is it working? Yeah. Some areas better than others. Some areas not so well. I think some of the big threats, number one, is that relationship piece. And again, I'm very proud that I've been able to work in an environment that doesn't damage relationships. It's not a scorched earth policy. We're not trying to cram these things down a provider's throat. Okay, other folks are. I think that's not sustainable, to be honest. The other threats, the members, as we just talked about, balanced billing, fear, misunderstanding of the program. Okay, there's so many ways you can combat that up front. And again, what I think what comes down to is this direct contracting. That's kind of the end game, right? Again, not a fit for everybody, not where we want to go everywhere. But I think if we get to that direct contracting point, people are getting paid fair reimbursement for services, and it's all working out. All right, I'm using the force, click. All right, here's a couple things that we've used. I'm giving away the farm here, I think, is maybe what I'm doing. Not really. No, here's some interesting things. If nothing else, I'm trying to give some visibility into some of the tools that are sometimes employed in maybe a claim negotiation setting, or even a self-pay setting where it's not hiring an attorney, it's not hiring a firm, it's just a savvy individual medical consumer talking to the billing department at a health system. Because again, we're all in this room because we're interested in a free market. So this is a little bit of a discussion of some of the tools that are leveraged to help get there. IRC stands for Internal Revenue Code. It's the best reading ever. Right? So terrible. What's interesting there is the Internal Revenue Code has a lot of mechanisms in place that really, at the end of the day, end up promoting this idea of a free market. Just nobody uses them. And we don't have the time to do a whole, Internal Revenue Code, Cliff's Note, how do you use the code to create a free market in medical delivery. But at the end of the day, my bullet points here speak for themselves. Again, I'm not getting into the detail, I'm just giving you some quick high level. There is a nonprofit issue that comes into play oftentimes, where sometimes a large system is billing a plan member, and as soon as that plan member gets an advocate that says, hello, health system, did you know that under Internal Revenue Code, blah, 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 XY, little I, 5021B, blank, blah, 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 you must provide this patient with financial aid options, with this, with that, with this. You have to go through this list of steps before you can bill him or her. Did you know that, ma'am? And then the collections person on the other end of the phone freaks out and hangs up. Because they can lose their not-for-profit status. There's not a big red light that goes off in DC and, IRC auditors come running out. That doesn't happen. But the point is, if they get audited, if there's a lawsuit, if there's a complaint filed, those things can come to the surface. So again, what I was trying to show you here is just some of some people may think these are terrible things, some people may think they're great, but at the end of the day, there's some tactics, there's some areas of the law that can help push things into that free market direction. All right, using the force. Here we go. Let me check that time one more time, or see if I got any update on the rodeo or fantasy football. Okay, we've got about, I think we're kind of shooting for 10 minutes and then Q&A. So really quickly, let me tell you just some of the other trends. I'm going to remind you, my world is very, very focused on self-funding, very, very focused on third-party administrators. So these items, we're not going to spend 10 minutes on each, just a minute, just want to kind of highlight them for you. Some of the folks in the room, you're like, I'm not going to touch this doesn't necessarily affect me. But I think if you have an interest in a free market, in the delivery of medicine, it's good for you to hear of these things and know of them, all right? Subrogation. I came up with this. Not subrogation, but I came up with this line. A free market holds the right pockets accountable. I don't know, somebody probably said that, but the other day I just sort of typed it up. I was like, this is cool, I like this. I need to give myself credit for it. But What I mean by this, a free market holds the right pockets accountable. Who knows what subrogation is? Who's not a TPA that's in the room? Should I put you on the spot? I won't do that. Super quick, super crass and dirty version. Subrogation is recovery of third-party dollars. There's more to it than that, because you got recovery, you got reimbursement, you got subrogation, different legal concepts. But basically it's this. Health plan pays out $200,000 for Johnny's back surgery after Johnny got smashed at a red light. Hooray for the health plan, taking care of their people. A year later, Johnny gets a settlement from the insurance company, the auto insurance company, covering the drunk kid that slammed into him. Right? Typical plaintiff attorney thing, blah, 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 lawsuit. So Johnny gets $1 million because he got slammed into by this other person, and Safeco. I'm just saying that's the insurer up in my neck of the woods that comes to mind. Safeco pays $1 million. So now Johnny's got $1 million. The health plan, so many health plans don't even realize they're entitled to be paid back. Not because they're mean, not because they want to take Johnny's money, but wait a minute, they paid $200,000 for Johnny's back surgery when it should have been paid by this kid that smashed into Johnny and or that kid's insurance carrier. So a year and a half later, those dollars do come in, time to subrogate. And again, there's other terms, reimbursement, recovery, da-da-da-da-da, but at the end of the day, that's the idea. Let's go get those dollars, not because we were mean to Johnny, we want to take Johnny's $1 million, but because, hey, Johnny, come on, man. That $200,000 that your plan paid out, got to get some of that back to the plan. You got other people that are covered by this plan. It's a solvency issue. It's the right thing to do. Okay? So that's why I say subrogation. A free market holds the right pockets accountable. This is way downstream. This is way after claims are incurred, years after claims are paid, years after third-party dollars come in. So you have to really walk through that line, but you can see where something like this assists in creating a free market because, again, it's holding the right pockets accountable. I jump up and down all day, every day, that subrogation is key to the lifeblood, the health of any health plan, fully insured, self-insured, I don't care. And I do believe that subrogation done properly assists with the free market. Other crazy ideas, some are terrible. Actually, they're all really good, but some people may think they're terrible. These are things, again, going back to my world, these self-insured health plans, things you can do. Choice of hospitals. If you go over there, Bob, your co-insurance is lower. If you go over there, good luck. You may not walk out. Cash economy, report as self-pay. I told you my stories. I actually know employers, and they reach out proactively through the assistance of their consultants and brokers, usually in smaller areas, not necessarily in large urban areas, but they'll reach out proactively to the provider community. They'll work out some interesting models. I heard people talking about the capitated model, different things you can do. Sometimes the self-pay conversation starts that. But where I was going with that is I know some employers that sort of just tell their folks, just show up and pay some cash. We'll work it out on the back end. I'm not getting into income tax, legality issues of that. I'm not recommending it. But I'm just telling you, I've seen some really interesting things that people are doing. Medical tourism. Keith, I put your name in here without asking. If you need to smack me in the hallway, go ahead. And there's plenty of models out there, so I don't want to, I'm not partners with Keith, disclaimer, la, 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 la. I will say I like Keith. Keith has been up to Idaho. We talked about deer hunting. And in my opinion, the Oklahoma Surgery Center, was one of the first on the scene doing this model, and I have a lot of respect for it. So thank you, Keith, for what you're doing here. So again, truly, this isn't like a plug. He's not paying me any money, but I just say this as a quick, what else are people doing to promote free markets? Medical tourism. A lot of plans are building it in. As you can imagine, it's typically that self-funded plan. A lot of freedom, different things you can do. How do you build it in? There's some stuff we do, actually, on our plan. We incentivize our people. We say, look, if you want to go see Keith, for example, let's figure out what it would cost you to have this procedure done in network in Boston. Because again, most of our employees are in Boston. I'm one of 4 out west. But what would it be to go over here and go to this hospital in Boston? We'll figure out the difference. We'll fly you out there. We'll give you 5% of the savings. We'll pay for your travel. We'll pay for a companion's travel, per diem, the whole 9 yards. And the plan still saves money after paying that out. Okay? Okay, I think I've got one more slide where, again, all I'm doing right now is a laundry list of some kooky fun things that we're doing and that I've seen in the space that I think are helping to create some fair payment models. This one is interesting. And this is like this could be the start of a 2-hour conversation on consumerism and member responsibility. And that's incentivizing the plan members to make smart choices with their health care. We were talking about it last night after a delicious 3 beers that I had. We were talking about last night the car insurance model is what you and I were talking about last night. That so many people, so many insurance consumers view insurance as a right. It's not about claims. It's not about if I'm going to utilize it. It's about when, and that I sure will utilize it. Well, what if we could start to incentivize our people to think more like consumers, like car insurance? When your grandma smashes into your car in the driveway at Thanksgiving, do you make a claim? 9 out of 10 people are nice and don't, and they like their grandma. Maybe they don't if they ask for cash from grandma. I don't know. But you get where I'm going. Maternity care. You're like, Tim, you're not making sense with the diaper thing, but bear with me. What we've done is we've put incentives in place where we say, hey, if you go to this hospital to have your baby for the next 12 months, bad example, you're a guy, but I just looked down. That was quick. Sorry, we're good. You go to this hospital to have a baby, we'll pay for it. It's under the plan. You go to this hospital to have your baby. We've vetted it out. It's a good hospital. You're going to have good results, but it is going to be cheaper for us. And because of that, we're going to pay for diaper delivery service and wipes every month for 12 months. Super simple idea, but it now promotes consumerism, right? It now incentivizes that plan member to think about where he or she is going and why. Now, why is it incentivizing him or her? I mean, the almighty dollar speaks, right? But if that's what it takes, it's worth a shot. I'm going to skip to the last one, and then I'd like to get into questions. Percent of savings, same idea. This is some stuff we're doing in our plan. It's kind of fun. We tell our people, and we kind of train them and help them understand, hey, when you get those bills, not that anyone's trying to pull one over on you, but take a look at them. See if you got charged for that Tylenol 10 times, or whatever it might be. And if you find an error, let's work together, and we'll give you 5% of the savings that you identified on the error. Or, this was actually something that happened. We had a plan member go out and find the same nebulizer for significantly cheaper on Amazon. I think what we did there was give him like a $50 gift card. I can't remember, to be entirely honest. But my point is incentivizing members to think like consumers. Think back 30 minutes ago when I was saying, look, we're all in this together. It's time to stop being us versus them. It's time for everybody to be accountable and try and fix it together. From the pricing to how much we're paying to the consumer being educated and thinking about what he or she is doing, what he or she is consuming. So just some examples of some of the stuff that people can do. We know what the problem is. There's a lot of ways we can fix it. In terms of my time with you today, hopefully I educated you a little bit on self-funding, the TPA model, which I do think is a great model to try and fix it. Talked about some interesting mechanisms that are in place to try and promote that free market. And a few quick laundry list items, things that we're seeing out there that are helping to get us there. Love to take some questions. Love to take some advice on my fantasy football team. Whatever you guys got, I'm here to help. And hopefully I haven't made anybody mad, but truly, we're all in this together, and so I'm here to help if I can. So, questions, comments? Throw food? Yes? I can repeat it for you guys. Or do you? Is that a mic? Is that what that is? That's a mic? It's like a box of Kleenex.
Hello.
That's cool.
In your last model, you were pointing out that if you go a less costly hospital, you can provide additional services, I guess you'd say. Kelly said that good doctors don't go to hospitals that aren't good. And then earlier on, we were talking about the fact that because a hospital looks impressive. It has to be impressive. How do you get over that chasm, or do you just go through the cliff and climb up the other side?
Yeah, so what you're talking about, if I'm hearing you, is that perception issue. Is that right?
Yes.
Consumer perception. I would say, and this is going to seem like a really simple answer, but what I'm going to do is I'm going to step back to before I came to the FIA group, and I was counsel at a TPA, and I was involved with our account management team, and I was assisting in open enrollment meetings, et cetera. So again, this will sound like a simple answer, but it's interesting to me that so many people don't do this. It's education, 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 education. It's almost marketing, right? It's almost like guerrilla marketing. And what I mean is, and it may never work, some populations are going to trust or distrust till the end of time, whatever it is they trust or distrust. But what we found to be successful is trying to engage, especially the medical stakeholders in the community, and have them come in and be part of the conversation with that employer-sponsored health plan and its members, and talk about results. A lot of people are data hogs too, right? People like data. People like to see metrics. So that's another thing we can do. I don't necessarily mean we, but like people. If you can show the data in terms of results on the care, you can start to get over that perception. You are correct. I would agree with you 1,000% though. It's the same thing when I get on this plane later today to fly up through Denver back to Boise. You know, you look at it, and if like the fabric's coming off on the seat in front of me and it looks dirty, you go, well, God, how's the engine on this thing if they don't even, you know, right? Perception. It could be the best plane ever, the safest plane ever, but I might start screaming and kicking and someone will film it and they'll drag me off, you know, or whatever. You're right. So that would be, I mean, that wasn't an overly scientific answer, but I have seen it very successful, that when we boil it down and try to make it less complicated and say, well, let's just work on educating our people. It's almost like marketing. You're right, that is a challenge. Because if it's shiny and pretty, it must be better, right? I appreciate that question. Yes. Do you want the Kleenex box? Those things are cool.
Concerning balance billing on reference-based pricing plans, is there any case law? Like, have any of these like gone to the court and the jury decided to create some case law on how the outcomes of those?
You know, yeah, but not really. And here's the reason. When push comes to shove, a lot of times, and there's kind of two ways these lawsuits can go. And let me answer it this way first. When push comes to shove, number one, most people are judgment proof. And I used to be one of those dirty, rotten litigators with my picture in the phone book, just suing everybody. So that was one of the conversations that I would have, or defending lawsuits. So this concept of judgment proof is this. You come to me, and let's not even talk about healthcare for a second. Let's just talk about someone's going to sue you. Your neighbor's going to sue you because your trampoline blew into the fence, for example. But, you know, maybe that happened. I don't know. They're going to sue you, and they're going to sue you for $1 million. You come to me, and you're freaking out. You got a demand letter. It's got letterhead, and it's got Esquire, and you're like, I would say, all right, let's walk through. You own your home? Cool. How much equity do you have? Oh, you got $10,000 equity. You own your rig? Yeah. Okay, what is it? You're a plumber. So that's your work rig. I would get on this laundry list and go, great. Let them sue you. Let them get a judgment. And they will garnish your wages at about $2 per paycheck for the rest of your life. Does that bother you? And you go, no. Go right on. Most people on the plaintiff's side, attorneys, legal counsel, et cetera, also do that math and understand, why would we do this? So in the healthcare world, what I'm getting at, you can see imagine being married to me. My wife, like this is how I talk. I'm like, I do all these stupid metaphors. But in the healthcare world, it's the same thing. Let's sue somebody over a $100,000 balance bill. And that somebody is an $18 an hour wage earner on a factory floor. Good luck, right? Excellent point. So his comment was, aren't they going after the health plan, which does have the money to pay it? Maybe. And here's where a properly built health plan that's being administered correctly comes into play. Remember early on we were talking about, again, because full disclosure, I'm like a self-funded nut. That's what I believe in. I love it. And I was talking about the plan document, right? So much of what you're getting at is because a plan document, or in the fully insured world, a policy, that document, that 100-page thing that governs that plan, isn't written correctly. And I'm not blaming anybody, but it's leaving out gaps in terms of you're due 150% of Medicare for all out-of-network claims. That's what it says. And this was an out-of-network claim. So sue the plan all day long, and If that gets dragged into court, that language is legal. Now, again, I'm leaving out a lot of nuances, but for our example, if the plan doc is written correctly to support what was paid, and it was paid pursuant to the plan doc, that's it. This may sound draconian, but at that point, the balance bill is the member's responsibility. So you're right that initially the deep pockets appear to be the plan. But as long as the plan document is structured correctly and it's been administered and paid correctly, it's a good luck. It's a good luck sort of scenario at that point. They're not going to win, is what I'm getting at. So that was kind of a long answer. I don't know if I kind of answered it. Now they may, there's plenty of people that are willing to rattle that saber and do what I like to call a nuisance lawsuit, just kind of sue for the sake of trying to get some money and see if they'll go away, even if they know they're not going to win. That stuff happens. So much of it, though, is what's going on the front end in terms of plan design, education of the members, and having a good administrator paying those claims appropriately according to the plan. Because what happens a lot of times in your scenario is the plan document could be awesome, and it could line it out, but maybe the administrator, the payer, the system was set up wrong, something happened and it wasn't paid correctly to where there is some room to go back and recoup those dollars, for example. So, yeah. Yes?
Matt Weiner from Detroit, Michigan. There have been 34 companies in the state of Michigan that have recently sued Blue Cross Blue Shield of Michigan under the ERISA statute for the hidden fees and the lack of transparency. How does that play into building a self-funded plan, and how can transparently priced providers leverage these lawsuits to be able to go to some of the TPAs and the employers who have been resistant to explore some of these less opaque, lower priced plans?
I think ultimately what it does, I think step one, it starts to dismantle the misnomer of network discounts, right? Because in my mind, and again, everybody's been on a network their whole life. That's the model, it's what we're used to. A lot of the stuff I'm talking about today, people are like, what, that's new, I've never heard of that. So I'm not saying it's bad or good, I'm not blaming anybody, but networks, as they currently exist, you get a discount off of an inflated starting point that means nothing, that's based on nothing, that's completely fabricated. So your 30 or 40% discount off of some insane charge that again means nothing, it has no basis, it's not a discount. So I think where I'm going to answer your question is this idea that by starting to dismantle the network, starting to dismantle the belief in the network, the consumer trust in the network, once that starts to go away a little bit, it opens up these other options as viable options, right? When suddenly the discount isn't as real, isn't as tangible, isn't a discount anymore, suddenly an employer, a broker that is trying to find an option for the employer is more amenable to these ideas that otherwise might have seemed scary, too renegade, I think. But yeah, no, we've been watching Michigan, and full disclosure, now that I've moved into this role, running around the country talking a lot, I don't follow the case law as much every day as I used to, but we've got guys like, we've got our team attorneys that are dorks that just sit all day, and they love that stuff. So I would, here, shameless plug, tune into our webinars every month if you don't. They're free. And it's just guys like me, Adam Russo, some of our guys that do nothing but follow politics and case law talking about stuff. So check those out, just good information all over the industry. So how are we doing here? I don't want to. Two more.
I'm an employer with a self-funded plan using a TPA. By the way, I love mutton busting. I'm from Boise, Idaho.
You're from Boise?
Yes, sir.
Yes, all right.
I'd like to go back to the question before the last and drill down on our plumber and the balance billing out of network example. I would love to deal with my claims like that. The problem is that the member's perception, when it's his job to have a lawsuit with the hospital, has told him that my health plan is trash.
Yes.
This is no good. He's not prepared to deal with it. That belly button does not operate in that venue. What can I do to bring the hospital, in this case St. Luke's, what can I do to bring them to bear and stop this nonsense? Yep.
Short answer, it may seem simple, but it's 100% real, patient advocacy. And it is outsourcing, so it's probably hiring a vendor. There's some that do it better than others, but a good patient advocacy program is absolutely essential to what you're suggesting, to solving balance billing issues. There's really two ways to handle a balance bill. Just one is aggressive claim negotiation. Let's throw a bunch of legal mumbo jumbo, but you and I both know, you're from Boise, I'm from Boise. It's growing, but it's still a small community. We all see each other at the Broncos game or golfing or whatever, and we don't want to alienate ourselves, especially as an employer. You don't want to be blackballed from one of the two systems. So instead of scorching the earth, it's better to try and negotiate the claims in good faith, maybe end up with a direct contract. That's going to be outsourced. That's going to be you, through your broker, through your consultant, hiring somebody to assist doing that. Or if it's just something that's systemic in your health plan because of your payment structure, not because your TPA is probably doing a great job, but it's just maybe you got a little reference-based pricing is what I might be hearing, or for whatever reason, there's balance billing, there's provider pushback, the patient advocacy program is key. People do that in-house. There are TPAs that do it. And then there's vendors that do it. So there's options, but I would say patient advocacy, patient advocacy, patient advocacy. There's also plan advocacy. A lot of people go, isn't the same thing, Tim? And no, it's actually, from a legal perspective, I would argue it's a conflict to have one entity advocate for the financial rights of the plan while also advocating for the financial rights of the member. So you can double prong it, and you could have an entity that's over here advocating for the plan's rights while you have an entity advocating for the rights of the member. And ultimately, it's going to come to a good resolution. But patient advocacy, talk to me more after. I could, refer you to some great resources. The one thing that really works there is a good patient advocacy program reaches out and touches the member, the belly button. It's not just behind the scenes working with St. Luke's. They're going to call Bob. Bob, you're getting balance billed. You're freaking out, aren't you? Yes. No, I'm here for you. I'm Joyce. Call me. Here's my number. I'm going to help you write some letters. You send me what they're telling you. Let's get on the phone. Let's work together. So,
okay, thank you. Yeah. That's what I'm not doing.
I guess we had one more and then running around. I don't know who was supposed to be.
Over here. I wanted to ask about subrogation.
Yeah.
Does your group manage subrogation for the employers, or is that relegated to the health insurance companies? The reason I ask is because I've seen that clause fraught with the potential for fraud.
Yeah.
The insurance companies have said, okay, well, the hospital has charged this much money. The employers, they've drafted that dollar amount out of their fund, and then the payer is then reducing the amount owed to the hospital because of an overpayment. And
okay.
Yes, I'm using air quotes.
Sure.
And that savings then they're getting a percentage of. So, they're not making a lot of money on their TPA fees by being a TPA in a self-funded market. I believe that the majority of where they're capturing the revenue is from these percent of savings under that subrogation clause.
Sure. So the short answer is, so there's numerous different models, as you just pointed out. And again, not here to sell anybody anything, so I'll just speak to what I know. The way we do subrogation, there's actually a variety of ways, but the way we found that works really well is we work with the payer, claims feed, we're analyzing the claims real time up front, and through coding, other means, we identify if we believe there might be third-party liability, we start working those claims immediately, investigating, et cetera, et cether, et cetera. So I think your question was, use the word manage. Are we managing the subrogation process or the cases? So I guess I would say yes. And then there's other models where sometimes maybe a plan or through their broker or their payer will sort of self-identify ad hoc and pick one or two and then send them out to a vendor and say, hey, help with this. We're going to do it in-house. I think, again, not trying to sell anybody, honestly, but the model we've got is a good model, looking at those claims early and up front and sort of owning it. But again, you want to cater to the noise, you want to cater to the will of the plan, of the employer, right? In terms of, do you want us to chase these dollars? Do you want us to leave your people alone? Do you want us to talk to you about each claim before we chase them, et cetera? So maybe I answered your question. I tried to.
But it doesn't really impact the employer. The employer's happy.
Well, as long as, at the end of the day, yeah, if an employer-sponsored health plan believes in subrogation, which they should, as long as it's working and there are dollars being returned, and it's never going to be 100%, side note. Because I want to defend all subrogation vendors out there, whether it's mine or someone else's, everybody. There is no subrogation vendor out there that's going to get 100% of the dollars recovered. It just doesn't happen. It just won't happen. That's a 2-hour seminar on state law and the common fund doctrine and made whole, blah, blah, blah. It's just not going to happen. 50 cents on the dollar, 30 cents on the dollar. But the employer is happy to get something back. So I think, are we wrapping up? Okay. Thank you, guys. Appreciate your time.